Welcome everyone. Let me talk about my PhD thesis, the role of regional anesthetic techniques in enhancing recovery after cardiac surgery. Oops. This one. 1/3 of cardiac surgical patients experience severe postoperative pain requiring high doses of opiate analgesics. It is well documented that this can lead to various complications and delayed recovery. Therefore, developing opiate-sparing analgesic techniques is highly important. Our systematic review and meta-analysis showed, which is based on randomized controlled trials, that thoracic fascial plane blocks can reduce pain by 25%, and reduce opiate use up to 40%. Therefore, they should be implemented in the daily cardiac analgesic practice. However, the optimal pain management technologies for minimally invasive surgical approaches should be further studied. The enhanced recovery guideline after cardiac surgery should be revised based on our data. My name is Tünde Szalay-Frank. I'm a specialist in anesthesiology and intensive therapy. My vision is that regional anesthetic techniques become part of enhanced recovery guidelines in cardiac surgery, and my mission is to take an active part in that as a researcher and a clinician as well. In order to achieve my goals, we launched 2 projects last fall, both of them investigating the efficacy, safety, and other potential beneficial effects of thoracic fascial plane blocks. First, let's talk about my first project, investigating the safety and efficacy of additional thoracic fascial plane blocks in patients undergoing cardiac surgery. Out of 100,000 people, over 100 undergoes cardiac surgery yearly. We know that the mortality is low, but up to 1/3 of these patients can experience some kind of an adverse event, and pain is the most common one. We know that adequate pain management has a pivotal role in enhancing recovery. We also know that cardiac surgical procedures are very painful and their anesthesia is highly opiate-based. Additional fascial plane blocks are already part of enhanced recovery protocols for other types of surgeries, but their role in cardiac analgesia remains uncertain. As you can see on the picture, there are several types of blocks. We can choose them according to the site of the surgical incision. We can administer the local analgesic either by single shot or injection or via placement of a catheter. Both of these procedures are done under ultrasound guidance, and due to this, the rate of adverse events is very low. Our aim is to investigate the efficacy and safety of additional TPBs in anesthesia for cardiac surgery. Our clinical question is the following: do additional TPBs enhance recovery after cardiac surgery compared to conventional analgesia? We are using the PICO framework. The patients are patients undergoing cardiac surgery. The intervention is adding TPBs to conventional analgesia. The comparator is the latter. Our primary outcomes are postoperative complications such as pain, bleeding, surgical site infection, prolonged extubation, or prolonged length of stay. Our secondary outcomes are opiate consumption and time to mobilization. Our hypothesis is that TPBs enhance recovery after cardiac surgery. We conducted our systematic search in 3 databases with the search key you can see here, consisting of 2 domains. First we had over 14,000 results, and after duplicate removal and selection, we ended up with 79 eligible articles. Here you can see the progress of my first project. We are right now in the risk of bias phase. We are planning to finish with this by the end of this month. Let me show you some of my results. The first plot shows the postoperative pain measured at the 12th postoperative hour at rest. The pain is measured in two scales, visual analog scale and numeric rating scale, both of which ranging from 0 to 10. 0 means no pain and 10 means intolerable pain. We included 20 studies, and we have data on over 1,200 patients. We have made subgroups based on whether the block is performed before or after the surgery. And as you can see, the result is expressed in mean difference with a confidence interval of 95%. Here you can see, hopefully, that the heterogeneity is very high, is 98%, which is due to the various types of blocks and various types of surgeries included. Here you can see that our result, our mean difference is minus 1.15, which means that the block can reduce the pain by 1 point at the visual analog scale, which is statistically significant. Our next plot shows the postoperative pain measured at the same time point while coughing. The heterogeneity subgrouping are the same. We could include a bit less studies here because this score was not reported in all of the studies. These are data on over 600 patients, and you can see that the mean difference here is 1.34, which means that the block can reduce the pain with 1 point at the vision analog scale even when the patients are coughing, which is statistically significant, but their clinical significance can only be seen in the light of this plot, which is the intraoperative fentanyl consumption in micrograms. We have here data, we made here subgroups. The end of surgery subgroup is just out of curiosity. We are not expecting any difference when the block is performed after the surgery. So we should see the result of the first subgroup, where you can see that the mean difference is minus 271, which means that the patients who are getting a block before the surgical incision require way less opiates during surgery to reach around the same pain scale after the surgery. I won't talk about this one. It's the length of ICU stay. We detected a statistically significant difference, but it means that the patients with block are staying 9 hours less at the ICU, but it seems to be not clinically relevant. The strengths of our study that we only included randomized trials. We see consistent results despite the high heterogeneity, and we could investigate a high number of patients. But we have some limitations. We have very few data on minimally invasive surgical methods, and the block-related complications and the potential confounding factors are not clearly reported. Despite of this, we can draw the conclusion that TPBs are safe and effective opiate-sparing methods, and they should be included in the daily cardiac analgesic practice, but we should further research the optimal analgesic techniques for the minimally invasive surgeries. Let's move on quickly to my second project, which is planned to be a randomized controlled trial investigating the respiratory effect of these TPBs. We know that up to 10% of the patients can experience some respiratory complication after cardiac surgery, and though the etiology is multifactorial, postoperative pain seems to be one of the main causes. As you can see on the diagram, when the patients experience severe pain, then they have a lower respiratory function, and on the contrary, when the pain is moderate, the respiratory function is much better. As in the first study, TPB seemed to be safe and effective pain killer methods. So our aim is to design as RCT to investigate their effect. We are using here the PICO framework, and we are hoping that TPPs can become part of the enhanced recovery guidelines. In summary, I am planning to submit both of my studies, the first one this year in fall and the next one next year. And let me close my presentation with a quote from Franz Kafka: "Pets are made by walking." Thank you for your kind attention.
You said that spending 9 hours less in the ICU is not clinically relevant, according to you, intensivist specialist. Can you tell me why that is? Because does it depend on the time spent in the department? Because when someone would say that spending 9 hours less time in the emergency room, that would make a huge difference. Yeah. But maybe it's different in the ICU.
Yeah, thank you for your question. Yeah, I'm not sure about the importance of these 9 hours. I mean, I haven't worked abroad, so I can't really see how there the ICUs works. But as for us in Hungary, there are lots of logistical problems. So in Hungary, it's not necessarily when the patient is ready to leave the ICU, there's often no place at the other departments, so it's the 9 hours. I mean, it happens even when the patient doesn't belong to the ICU in Hungary. But I have to look into it, and I have to see whether the other studies or how the intensive care units work abroad.
You mentioned that one of the limitations of the study is that there is a lack of data about the confounding factors. Can you mention some of the confounding factors?
Yeah, usually, thank you for the question. At the beginning of the studies, there are lots of data about the patients, but it's far from complete. So sometimes we don't know about respiratory illnesses. Sometimes we don't know even not the rate of the reoperations. So that's what's a limitation. So a longer ICU stay can not only be caused by huge pain, but also other issues which are not really clearly reported in all of the studies.
I have actually two very short questions. The first is how did the authors in the included studies check the intensity of the pain just before the surgical incision, because the patient were already anesthetized, right?
No, I mean yeah, there are two types. When the study investigated the placement of a catheter, they usually done it in awake patients. So they could check whether the position of the catheter is adequate, and yeah, and in the other studies, they somehow they just supposed, because there is no surgery, they don't have any pain. So we don't have data before pain.
Super.
Data
Okay,
before.
I see that. And the second one, do you plan or do you investigate the long-term effects of this block, such as the chronic pain or the quality of life after this surgical procedure?
Yeah, thank you for the question. Yeah, this. I mean, it would be very interesting, but this study right now focuses on the perioperative issues, but maybe later.